we see that oftentimes when we get consulted to see patients, that we're the ones discovering these symptoms that have been present for some period of time because it isn't at the top of people's mind to assess for them. And when we think about the common assessment tools used in palliative care, such as the ESAS or the Edmonton Symptom Assessment Scale, none of these symptoms are on that scale. So it really begs for the clinician to have a little bit higher index of suspicion for the presence of these, particularly with some of the problems that Dr. Clark has brought out, that we need to be thinking about them more prevalently in our patient population and including them as our initial assessments.
Well, I think that for many clinicians, because mucositis is such a frustrating symptom to manage, that they have been using therapies, many times which, even though traditional and passed down from one clinician to another, have oftentimes had very little evidence for their efficacy. And so part of our discussion is making the clinicians aware of some topical therapies that actually might be more effective and have evidence that that is the case.
And as far as pruritus goes, I think we're still been searching about how to understand the pathophysiology behind the problem, and we're beginning to understand that it's a lot more like pain than what we ever really thought about, that there's a lot of common neurophysiology that is shared between pruritus and pain. And again, we've used traditional antihistamines and other medications we typically think for itch that don't work well in our patients. So we're discussing some new findings that talk about novel concepts of approaching this problem, some using drugs that we use for other symptom burden in palliative care, but also some new novel things that are actually in development and that hopefully we'll have as tools to our disposal in the near future.
I was going to say, and I think for sleep, we do need to screen for it and then assess it, because there's lots of reasons people aren't sleeping. One could be their pain, or in our case study, there's lots of symptoms that sometimes it's the treatment, sometimes it's worrying and just lots of things going through their head at different times during the night impacting it. But I think there are more interventions now, particularly such as cognitive behavioral therapy for insomnia, that there's more research, I think, in the last couple decades on non-pharmacologic therapies for sleep than actual pharmacologic therapies for sleep. And I think certainly in a lot of these complex patients, if there's something we can do without adding another pill or another set of risk factors, then we should explore that.
I think we've seen a lot of patients in the last few months that have had maybe not this exact constellation of symptoms, but have had 2 of the 3 in different combinations that have driven a whole cascade of events to occur that generally led to toxicities from treatments that didn't necessarily work very well, and the patient still had unmanaged symptom burden.
And we all work together as a team. That's part of the fun of this presentation, is that we actually sit many days in a team meeting together, and I think we all have that comprehensivist view of palliative care that has brought us to this discipline.
Speaking just about pruritus, I would say that please stop using traditional antihistamines to treat this problem, because they don't work and they're very deliriogenic in most of our patients, and so it just becomes a blind alley that you and your patient go down. So I would encourage clinicians to forget about antihistamines for the pruritus problems that we see in our practice, and we need to look at non-traditional ways of treating it.
I would say in the mucositis arena, it would be don't try to manage it with escalating opioids and so-called magic mouthwash or whatever variation of magic mouthwash there is. If that's where you're at, your practice should really be looked at afresh.
And I would say as far as sleep disturbance, it impacts the patient's quality of life and their family a lot, and we need to assess that, give them some tools, and there's things we need to do, particularly when they're inpatient, that we're kind of preaching for them to do on outpatient, but then we don't carry that through in the inpatient setting. I think there's lots of improvement we can make both in their home setting and in the hospital setting.
There are a lot of interesting things that are on the horizon, some of which aren't here in the United States yet, and so again we need to begin to reframe our thinking about how we've traditionally approached these and be prepared for new things coming down the pike, I think, very soon.